As is well known, Parkinson's disease is almost twice as much more common in men than it is in women. But why? We don't really know the reason for it yet. There are some clues from the preclinical studies that show that estrogen can have a protective role on neurons against several different toxic compounds. They are involved with dopamine function and metabolism, and they could even be involved in alpha-synuclein metabolism. But then, conversely, from a clinical studies point of view, the results are really controversial. More specifically, some studies show that symptom severity of Parkinson's disease can fluctuate during menstruation, pregnancy, menopause, but not all the studies do agree on that. And if little is known about Parkinson's disease, even less is known about early-onset Parkinson's disease, which is the version, let's say like this, when the onset is before 50 years old. So these are women that are young, that are fertile, that can have babies, so they have lots of challenges to work with. And so the aim of our study, so to analyze the hormonal exposure in EOPD women, and to compare their hormonal exposure with the one of unaffected controls and late-onset Parkinson's disease to see if there was actually a difference between the three that could explain the different manifestation of the disease. In order to do that, we retrospectively analyzed their charts, more specifically EOPD and LOPD patients, so early onset and late onset. We use the Mayo Clinic data management tool, which allows us to have clinical information about all the patients ever been seen at Mayo Clinic. And then we use the REP, which is the Rochester Epidemiology Project, to find the EOPD-matched unaffected controls. They had, let's say they were just 3 years more or less than the EOPD patient matched. And then we retrospectively analyzed their charts to see their hormonal exposure, meaning demographic characteristic, first of all, and then reproductive history, so menarche, did they use contraception, which type, for how long, did they have pregnancy, how many, miscarriage, breastfeeding, and then the menopausal history, so at what age they had menopause. Did they had gynecological surgery? So which type of menopause? Was it spontaneous or was by oophorectomy? And then the use of perimenopausal treatment, so HRT. And then we compared the different three groups, so EOPD with unaffected controls and EOPD with LOPD. And the results were that we didn't really find any significant differences between EOPD and unaffected controls, other than that controls were more likely to have had a history of hormonal contraception, but when assessing the use of hormonal contraception before onset of the disease, it was no longer statistically significant. So not really important, let's say like this. While with late-onset patients, we saw that there were several differences. More specifically, LOPD patients were less likely to have used contraception and were more likely to have had menopause, oophorectomy, and perimenopausal treatment. But these differences between EOPD and LOPD, in our opinion, could be related to the so-called age cohort bias, which is a bias due to the different ages of our patient, because of course LOPD patients are older than EOPD. More specifically, half of our LOPD patients were born before 1935, meaning they were already older than 25 years old when FDA approved the contraceptive pill in 1960. And so that could be the reason why they had less story of contraception use. And of course, it's intuitive that LOPD patient had a higher rate of menopause and of perimenopausal treatment and even of oophorectomies because they are older. And the majority, almost all of the oophorectomy were done postmenopausal, so not surgical menopause. So at this point, it seems unlikely that a difference in the hormonal exposure between EOPD and controls could explain the occurrence of the disease. And that a difference in the hormonal exposure between EOPD and LOPD could explain the different manifestation of the disease among all the earlier onset. Further studies that we are already conducting with a larger patient sample and a prospective data collection, because we retrospectively analyze their charts, is needed to further understand the possible correlation between hormonal exposure and EOPD, because I would like to underline that there is no study at all, or very few, that are analyzing the hormonal status of these EOPD patients.